This final paper is taking us to the global level, where ethnography is not often performed, but I'm going to try to show to you how ethnography can illuminate some of the topics that we often discuss in the hallways at conferences and in discussions with colleagues, but which rarely make it into research papers. So, as you all know, during the past 10 to 15 years, there's been a complete transformation in the global health landscape, with power shifting away from the World Health Organization towards a very complex array of competing and often overlapping initiatives, often incorporating public actors and NGOs that operate in what we call the global health arena. And these global health initiatives have often been lauded for getting specific health issues onto national and international agendas and generating research and resources, especially for attacking these issues. But critics have also countered that they represent a double-edged sword, because while they massively increase the resources that are available for global health, they also reinforce a business approach to governance and very circumscribed technical solutions to health. And they've also been criticized for distracting governments from their coordinated efforts to strengthen health systems by imposing a lot of conditions on what they can do. And it's partly in response to such criticisms that some of the most prominent global health initiatives, including the GAVI Alliance, which funds vaccines, and the Global Fund to fight HIV, AIDS, TB, and malaria, have in recent years expanded their disease-specific remit to support what they call health system strengthening. And my paper critically analyzes this development through an ethnographic study of the GAVI Alliance. And as I'm sure you all know, the GAVI Alliance was formed as a public-private partnership to pursue what it itself calls a single-minded focus on closing critical gaps in the provision of vaccines. But despite this self-proclaimed single-minded focus on vaccines, 10 years ago, in early 2005, the board started to widen GAVI support to countries to health system strengthening, which is often just referred to as HSS. Although most of GAVI's support to countries is still for the purchase of vaccines, up to a quarter of its funding support is now directed at achieving the strategic goal of, quote, strengthening the capacity of integrated health systems to deliver immunization. And between 2007 and 2010, GAVI disbursed over $315 million for HSS programs in 53 countries. Today, HSS support is fronted as a, quote, a key principle of GAVI's mission, and it has articulated a health system goal as part of its strategic goals. Yet, what I'm going to try to show is that what HSS means remains unclear and contested, and this contestation reflects really competing public health ideologies and professional pressures that operate within the global health field. And I'm going to try to show that in spite of adopting a rhetoric that is supportive of health systems and that is holistic, global health initiatives like the GAVI Alliance have really come to capture the global debate about health systems in favor of their disease-specific approach and business-oriented ethos, which is quite a paradox, really. So the approach that I'm taking here, as I already said, is to look ethnographically at the global level and to look at the debates around the health system's goal as part of a contested social process through which different actors negotiate their positions and their claims to legitimacy. And I draw on a combination of ethnographic methods, including analysis of policy and scientific debates, observations of debates as they play out in conferences and meetings and consultations, and also more formal in-depth interviews with a range of actors from different organizations, all of whom can really be considered to be members of the global health elite. And it's important to say that although GAVI's strategic plan and its public relations materials always stress the importance of HSS, or health system strengthening, it's no secret that the expansion of GAVI's remit in this way was highly controversial. As one of my informants said, HSS has probably been the most contentious issue ever within the GAVI board, and there were very strong camps on both sides of the debate. Others pointed out how the Atlantic Ocean separates a whole mindset on what health system strengthening means, with Americans generally being more technologically focused and European countries, with Scandinavia at its helm, being more in favor of a more traditional alma ata interpretation of health systems. And the idea of diverting some of GAVI's funds to health system strengthening was initially advocated by Julian Lobb-Levitt, who was CEO from 2004 to 2010, who argued that supporting health systems would be in GAVI's interest because strong health systems are necessary to achieve immunization aims. And his view was bolstered by a series of external evaluations that identified weaknesses relating to financing, human resources, and infrastructure as hampering the performance of GAVI-supported immunization programs. And these also recommended that GAVI should expand its remit to include health system strengthening in order to address these challenges. Sorry, how's this work? While the British and Norwegian governments were supportive of this recommendation to expand the remit, American actors were opposed, and at the helm of the opposition was the Gates Foundation, which, according to one of my informants, was a very loud vocal voice saying that we do not believe in the strengthening of health systems. Some of the issues that people who were opposed to the expansion of HSS support mentioned were that, health systems don't kill people, diseases do. And with health system strengthening, it's not clear what you're buying into, which relates to the issue that's been discussed in several sessions about the need for measures of accountability. As one of the people opposed to health system strengthening within GAVI put it, the term has been quite detrimental to disease control programs because it's not been clearly defined what it is. And he says that if you can get a TB drug to people, for example, those systems should be able to get other drugs to people too. So it's a matter of making sure that the systems used by one program are being used by another. So saying a range of vertical systems together aligned to make a health system. So for this informant, investing in health system strengthening is really just a myth. And while they acknowledge that disease control programs can indeed have positive catalytic effects for the whole health system, Lobb-Levitt and his allies really explained that one of the biggest problems with GAVI and indeed other global health initiatives like it has been an unquestioned assumption about these positive knock-on effects, which has been coupled with deep-seated resistance to actually monitor the impact of global health initiatives' activities on health systems. So, as he put it, everybody always says that, no, we do contribute to strengthening health systems and we do these great things, but there are no clear measurables, no clear objectives, and none of them will accept including these in their evaluations. So this is why he suggested that the health system windows was needed within GAVI, if only as a way to introduce more sophisticated thinking about how GAVI not only strengthens, but should also avoid undermining national health systems. Now, although the board agreed to divert funding to health system strengthening, this window, or this stream within GAVI, was very quickly marginalized. And the people who were advocates of it were marginalized from within the organization. There were rumors that Lobb-Levitt was forced out as CEO in 2010 because of his, quote, systems advocacy, highlighting how controversial this issue was. And according to a GAVI official who declared himself sympathetic of Lobb-Levitt's view, after his departure in 2010, HSS continues to exist, but has been really reduced to what he said, a vertical program within a vertical initiative, which is again paradoxical. In the process, the original health systems idea has been distorted. It was intended to be flexible support to countries to support systems in the way that they wanted, but the effort to compromise has resulted in a series of contradictions and weaknesses that, according to critics, really limit the ability of HSS support to contribute to integrated national health systems. And as one of those who'd been involved in formulating the original HSS proposal put it, a consequence is that most countries have come to use a kind of supermarket approach to health system strengthening. We have some vehicles here, some refrigerators there, but there weren't very strong strategies behind it. And independent analyses have similarly pointed to the way in which GAVI's HSS support has primarily funded selective interventions targeted at bottlenecks in disease-specific initiatives. And this critique really applies to other global health initiatives as well, such as the Global Fund. And in this sense, I would say the HSS strategy really fits squarely within what many global health actors now informally refer to as the Gates approach to global health, as I referred to in my title, which is really a shorthand for describing an increasingly powerful, business-oriented, and technology-focused public health ideology. And people call it the Gates approach because it has been propagated most forcefully by Bill Gates and his foundation, although many other actors endorse it too. And really within GAVI, HSS support has primarily come to signify a modality for achieving its primary aim, its vaccination goal. So many now refer to it as immunization strengthening support rather than health system support. One of the problems with this is that this distortion of the idea of health systems is not confined to GAVI, but now permeates really all of the global health elite. And there are many examples of the way in which GAVI has come to capture the debate on what health systems is. And for instance, in the WHO, which was a champion of comprehensive primary health care in the 1970s, we often now see a reliance on market metaphors in outlining the expected returns from investment from health system support. And strikingly, in public discourse, WHO now contributes to turning the critique of the negative impact of global health initiatives on national health systems on its head in favor of global health initiatives. So when, for example, Margaret Chan says in a speech in 2009 that weak health systems are almost certainly the greatest impediment to better health in the world today. But significantly, she says they are the central obstacle that blunts the power of global health initiatives, which I think is, again, a paradox. And another example of such capture is evident in the way that previously, quote, systems-oriented donors now approach health systems. And the way in which funding for health systems is increasingly being channeled through GAVI. There appears to be an erasure of this long-established Atlantic fault line in thinking about health systems that my informants talk about to an ideological convergence around the Gates approach. So, for instance, one of my informants, a British public health specialist who had senior-level experience from GAVI, noted that the UK government has recently, quote, moved away from health systems after, quote, very heavy lobbying from the Gates Foundation and the conservative opposition. And now they're very much more aligned with the Gates line of thinking. And a UK-based professor with extensive international policy experience noted the same shift in Norway. The people from Norway have been consistent advocates of primary health care, so they put big dollars into the WHO, but things have changed in recent years. Norway has stepped out of that field and has become a big player and lined up to some extent with the US-type approach, the Gates approach. Now, of course, donors' embrace of this approach not only reflects ideological convergence, but also the political expediency of funding global health initiatives through like GAVI. Donors increasingly perceive that they can now more easily exert influence through these public-private global health initiatives and through the what they often refer to as the unwieldy traditional intergovernmental system of governance. Global health initiatives have acquired a reputation for being more innovative and effective than intergovernmental forms of governments. So, for instance, at a high-level panel debate on vaccines that I attended in London in 2011, a DFID representative explained that DFID has decided to invest very heavily in GAVI, not only because vaccines are clearly cost-effective, but also because GAVI is an institution that we are confident in. It represents a good buy. And in a veiled denouncement of the WHO's inefficient bureaucracy, she elaborated, and we have to be able to tell the taxpayer is that we put money into an institution, that money will be stewarded well with ambitions. Problems will be sorted and something will come out the other end. And such comments really suggest that despite being a narrowly focused public-private partnership without a public mandate, and that's significant, GAVI is now often considered a more trustworthy alternative to the traditional publicly mandated multilateral UN agencies, including the WHO. And donors also prefer global health initiatives, they say, because they're incredibly high profile. And this means that bilateral aid to these organizations garner attention. they are also arguably successful, even only in terms of their own narrowly defined goals. And this makes it easy for donors who are themselves under increasing pressure to demonstrate aid effectiveness to claim results for their investments. So the Global Health Initiative model fits very well within the political cycle, because unlike intersectoral action and more comprehensive efforts to build up institutions and strengthen systems by training providers and providing infrastructure, it produces results quickly. And more generally, suggested one informant, they offer really a seductive solution to problems that appear to be insurmountable, whether that's extreme poverty or non-existent health systems. As he put it, the problems of the developing world are very difficult for people sitting in somewhere like Washington or London to imagine. That's when someone comes along and says, but hey, if we give them all pneumococcal vaccine, we'll save 1.3 billion lives instantly. We don't have to do anything else. We can just pay for the vaccines. It's easy. So of course, this is completely false, but it's easy. So immunization has been very easy to sell. And I would say that health system strengthening incorporated into this logic has made it an attractive way for donors to claim that they are supporting health systems while really just supporting this approach. Now, although I've outlined what I think is a convergence around this particular public health ideology that I've labeled the Gates approach, and which that's a way that people talk about it in the field, it's important to emphasize that there are many critical voices in the public health field. And in private, many of my informants actually question the legitimacy and the capacity of disease-specific global health initiatives like GAVI to set health systems agendas. Several WHO officials depicted the GAVI HSS investment as an infringement on WHO's mandate and claimed that it was actually part of a broader attempt to usurp WHO's position within global health. But many of those who privately voiced critical perspectives admitted that they found it very difficult to do so in public. And I think the evidence of that is that it's very hard to find published critiques of this approach. And this reflects, I would argue, a professional culture that encourages public displays of consensus around the Global Health Initiative model and that discourages or even stifles, you could say, open debate. And on one level, this culture of deference is indicative of how dependent many actors in the global health arena, from multilaterals like the WHO to elite public health institutions and, of course, national governments, have become on global health initiatives and on the private actors like the Bill Gates Foundation who supports it. They've been dependent on these organizations both for funding but also for professional prestige. And I think it's also indicative of the power that individuals like Bill Gates have acquired as global health leaders. And although he's often privately criticized for being incredibly strong-minded, quote, and his techno-managerial approach to health is often derived as naive in private, many global health actors also clearly venerate Bill Gates. When Bill speaks, people listen, I was often told. And with Bill Gates at its helm, the Gates Foundation and GAVI, which it supports, has surrounded itself with what one informant referred to as, quote, an aura of uncriticizability. And Gates' reputation for being, quote, not very good at listening has encouraged a non-confrontational approach within the global health arena that I think is significant, extends even to actors within GAVI. So a former GAVI employee and health system strengthening proponent recounted how he and his colleagues used to, quote, roll down the HSS posters when Bill came to visit the GAVI headquarters in Geneva because he's known to, quote, hate this part of GAVI's work. So such lack of open critical debate not only results from professional deference, but also from the value placed within the global health field on disease-specific technical knowledge relative to health system expertise, which suffers from low scientific status and has even been said to, quote, have an image problem. Disease-specific specialization is, as we all know, encouraged throughout the global health career trajectory, from training, recruitment, and funding. People make their lives around single diseases, said a self-proclaimed health systems expert in UNICEF, adding that he was the only person in his department who didn't have the name of a disease after his title. And he outlined, along with several others, that one of the problems now is that whereas health systems experts before sharpened their teeth in the health systems of poor countries working alongside low-income country governments and health professionals, today global health professionals tend to move straight from elite education in North American or European institutions to global health organizations with little or no exposure to low-income country health systems. And in fact, the UNICEF official that I just quoted said, people have become too accustomed to their elite lifestyle, cocktail parties, and fancy dinners to really want to get their hands dirty. So where does this leave us? GAVI has received a lot of praise for its foray into health system support. And some of this is legitimate. And it appears to, in doing so, though, have successfully propagated this idea that vertical investment or funding can be a good way to achieve horizontal aims like health system strengthening. However, I think it's wrong to interpret GAVI's HSS support as indicative of a new wave of horizontality in the history of global health after a long period of verticality, which Hafner and Schiffman have recently done in their article about the recent surge of interest in health system strengthening. I think this really obscures what is happening because GAVI's health system support actually has much more in common with past waves of verticality than with horizontality. It continues, for instance, the incursion into global health of a neoliberal ideology, and it introduces market metaphors in thinking and a preponderance for technical solutions to health problems that is not associated with a horizontal approach to health system strengthening. Within GAVI, the notion of HSS has been gradually narrowed and even distorted, increasingly meaning little more than strengthening components that are needed to achieve disease-specific goals. HSS has taken on a distinct and redefined meaning typical of the techno-managerial paradigm within global health today. And the ultimate irony, as one of the former GAVI officials I interviewed put it, is that the approach now among those supporting health systems is to work within the disease-specific approach, because there's no other way to get your voice heard. And so I think one of the most important effect of GAVI's HSS window is not really the money that it disperses to programs or the way in which it supports health system strengthening, but really the fact that creating this window has increased or has maintained or even increased the organization's power to set the global health agenda. It has contributed to removing debates about health systems from the political realm. Health system strengthening today is presented as a technical solution and is articulated within an internal foolproof logic of saving lives, cost effectiveness, etc. And this, of course, is part of this broader trend in global health to eschew complexity and context. Embracing health system strengthening has also contributed to silencing those who have criticized GAVI of its narrow focus on vaccines, because now, of course, the remit has been expanded, though not really. In the process, the Gates approach has been reinforced within the broader global health community, while alternative public health paradigms and discourses, like the ones that Alicia Yamin spoke about earlier today, have been marginalized. HSS support also justifies the shift that donors have enacted away from publicly mandated institutions like WHO and towards public-private partnerships. Incorporating HSS within the remit of disease-specific global health initiatives thus ironically serves to legitimize some of the very practices like private financing, disease-based initiatives, and a narrow focus on measurable health outcomes that have arguably contributing to decimating poor countries' health systems in the first place. So thank you very much for listening.